Good afternoon and welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and then also please remember to take and fill out the program evaluation, and the CME committee would be quite interested in any ideas that you might have in regards to future topics or future speakers. Today it's my pleasure to welcome back actually Dr. Scott Vogelgesang. Dr. Vogelgesang is an internist and a rheumatologist. He is a professor at the University of Iowa, where he's been recognized not only for his excellence as a clinician, but also as an educator. And he has served as the director of the internal medicine residency training program there, and also as the director of medical student education and physician training. And the CME committee is quite pleased that he was able to accept our invitation to come to Ames today and update us on systemic lupus erythematosus. And please join me in welcoming Dr. Scott Vogelgesang.
Thanks. Is the volume okay? Okay, good. I see at Mary Greeley, it's the same at the university. Everybody sits in the back. It's nice to be back. The construction looks fabulous. I have to tell you, you have a beautiful facility here. It's been a little while since I've been back, and I walked in and went, oh yeah, this looks familiar, but boy, is this gorgeous. So it's lovely to be back. I'm going to talk about lupus today, and this is a broad topic, but we can go in any direction that the audience wants to go. So give me a sense of who's here. Just shout out specialties, what you're doing. Okay? Okay? All right? Okay? Okay? Okay, so broad range. So I'll keep the topic broad, but if we want to shift into something a little more specific, just ask me. This works better if it's interactive. So here's what I want to cover. I'm going to talk about epidemiology, natural history a little bit. We'll talk about making the diagnosis of lupus. We'll talk about the clinical manifestations. We'll talk about the laboratory manifestations. We'll talk about therapy, and I'll summarize it. And when the invitation came, there was a specific request to talk about lupus nephritis. So I will. And we'll talk about the therapy of lupus nephritis, although how much we go into that is really up to you, because that can be a talk really in and of itself. You'll notice throughout the talk that the lupus criteria, the diagnostic criteria, is highlighted in light blue. So it'll be a way to sort of ground yourself in what I'm talking about. Epidemiology, women outnumber men, and it depends on which age group you're looking at and which study you're looking at. It can vary anywhere from 5 to 10 to 1, but much more common in women than in men. The peak incidence is ages 15 to 40, closer to about 30. It's not very common. In the general population, it's about 1 out of every 2,000 people. The genetics are interesting. If your sister has lupus, your chances of having lupus are 25 to 50%. Your identical sister. If you have a non-identical twin, or if your older sister or your mother has lupus, it's really only about 4%. So oftentimes when I'm talking to people in the clinic, they want to know, what are the chances that my daughter, my sister, my cousin is going to have lupus? And then the other question that they ask is it genetically related? And the answer is yes, but not as scary a genetic statistic as people might think. The natural history, people think that if we make this diagnosis of lupus that their life is over. And I think that some of that comes from the perception of the data from the 1950s, in which the 5-year survival rate was about 50%. Therapies weren't as good, and just people didn't do as well. And now the 10-year survival rate is about 90%, or actually maybe even better. So therapies are a lot better, diagnosis recognition is better, hemodialysis, transplant, all kinds of support has made the diagnosis of lupus maybe not so scary. Now, though, with longer-lived patients, we're seeing atherosclerosis and cardiovascular disease becoming a bigger problem. The other thing that people want to know about is, what's my prognosis? And the answer is it depends on which organ systems you have that are affected and how severely they are affected. So the question always comes up, what causes lupus? And that's always a hard question to answer. And so at its most simple, it's really antibodies directed against the self instead of against infections like it's supposed to be. However, a more complicated answer is that it's really this complicated mix of genetics, innate immune system, the adaptive immune system that involves having the genetic predisposition, having some kind of a trigger when you're young, and then the immune system revving up in a way that it's really not designed to do. Questions so far? We doing all right? Okay. So anybody know what percentage of patients with lupus will have a positive ANA? This is a good lab question. What do you think? I heard 180. I heard 193. This side of the room is really quiet. So the answer is E, 93%. So we think about ANAs as being associated with lupus, and in fact, most people that have lupus have a positive ANA, but we'll talk about it. The ANA isn't all it's cracked up to be. So the diagnosis of lupus is really made clinically. There is a set of criteria designed by the American College of Rheumatology, and the mnemonic that we teach is SOAP Brain MD. So there are 11 criteria to make the diagnosis. We need 4 out of these criteria. And so serositis, oral ulcers, inflammatory arthritis, photosensitivity, we're going to go through these in detail. Blood abnormalities, renal involvement, ANA, immunologic abnormalities, neuropsychiatric, malar rash, and discoid rash. So I think most of these are familiar to a lot of people in the auditorium. Here are the specifics as you break down, for example, the blood, the renal, the immunologic, the neuropsychiatric criteria. And the real utility of having the diagnostic criteria in your back pocket, in your memory, in your phone, which is where I put everything now, is it gives you an organized way to think about a disease that has seemingly 1 million different manifestations. And so now I have an app that has what look like note cards to tuck all those things away, and when I'm in the clinic I can pull it up. It's really quite useful. Now I put this up, this is hard to see, but this is a new set of criteria for the diagnosis of lupus that was put together in 2012. It's not that much different than the American College of Rheumatology criteria, but this was designed by a bunch of clinical researchers, and one of the things that they wanted to respond to was if we had a patient who had a positive ANA, had renal disease, and on the biopsy, the renal disease showed classic lupus findings, they really only have maybe 2 lupus criteria, and yet all rheumatologists, maybe that's too strong a statement, many rheumatologists would agree that this is somebody with lupus. The criteria then doesn't support that, and those people can't be enrolled in clinical studies. So they came up with this alternate set of diagnostic criteria to support clinical research, particularly as it relates to lupus nephritis. The interesting part about this is that it really hasn't been widely adopted. The clinical researchers have really pushed this hard, but the rheumatology community, and in fact the nephrology community as a whole, have been sort of dragging their feet a little bit about adopting this criteria. So that was in 2012. Now we're in 2016. Hasn't been adopted yet. I don't know. Clinical manifestations. So the first thing that we see is oral and nasal ulcers, and classically we see these on the soft palate and the buccal mucosa. And again, classically in the textbook, they're painless. The real problem is that these are difficult to distinguish from common aphthous or canker sores. And I'm just curious, how many in you in this audience have ever had a canker sore in the inside of your mouth? And that's the problem. This is really a soft criteria, so it's very common in the general population. And so it's hard to to use that as a diagnostic criteria. Skin involvement with lupus is fairly common, and it's really broken down into 3 categories: acute skin findings, chronic skin findings, and somewhere in between. So the acute skin findings, most of us are pretty comfortable with seeing the malar rash, the butterfly, goes across the bridge of the nose and spares the nasolabial fold. You can also see diffuse erythema, and that's picture B here, in which this young woman went out in the sun and developed a bright red rash everywhere that the sun reached her skin. And then there's a weird kind of rash in panel C down here, in which it's between the joints and interarticular. And all of these 3 at least are photosensitive. So if a lupus patient goes out in the sun or gets in UV light, they pop up with these kinds of rashes. Now the chronic form is the discoid rash, and classically that's described as annular or round. It's erythematous, so the border is red, and then there's usually central clearing, and in that central clearing there's usually scar, the follicles are killed, and the skin atrophies. And so if you look at this young fella's head, with the discoid lesions on the top, there's not hair growing in there, and probably there won't be because they've been destroyed. Now there's the acute, the chronic, and then this is the in-between, subacute. Now this comes in a lot of different kinds. If you look at this one, this is called the papulosquamous form, and it's just sort of red papules. It may or may not be photosensitive. But if you look at this panel over here to the right, this looks a lot like discoid lesions. It's annular, it's red, maybe has some scale. In the interior part of it, it's clear. What makes it different is that there isn't any scarring and there isn't any atrophy. So if you treat that lesion, chances are pretty good it will go away, as opposed to the discoid lesions, which tend to stay fixed. And the other thing to take away with this, or from this, is that these subacute lesions are associated with SSA and SSB antibodies. Now we talked a little bit about photosensitivity, and I put in small letters, we're not talking about photophobia. Not quite sure why. A lot of people come into the clinic and they're confused, and they'll be wearing their sunglasses and they'll say, "See, I have lupus because the sun bothers my eyes." Photophobia is something different. Photosensitivity is when somebody goes out into the sun and they get exposed to UV light, they develop a rash. And in fact, they not only develop a rash, they develop immunologic activity and immunologic stimulation. So what happens is lupus patients have circulating antibodies against all of their self. And in all of us, most of us here in this room, if we go out into UV light, what happens is the UV breaks up some of the cellular constituents. It's a normal part of what happens. And those little cellular constituents then get chewed up and they get processed. But lupus patients, when those cellular constituents are opened up, they have antibodies that grab onto those. The antibody-antigen complexes then are relatively heavy, and they drop down to the junction between the dermis and the epidermis and sit there. And because they're immune complexes, then complement gets fixed, the immune system gets activated, and the worst episode of this that I've seen was a young woman who, during my fellowship, was a senior in high school. She was getting ready to graduate. She was very bright. She was going to go on to college, and with a lot of her friends, she went down to spring break in Florida, laid out in the sun, developed photosensitivity, and her lupus just exploded, and she developed bad renal disease, and in fact, she couldn't go to college because she was in the hospital being treated with hydroxychloroquine and cyclophosphamide. And she got all the way through that year, got pretty good control over her health. And in another thing characteristic of particularly young lupus patients, when it was spring break, guess what she did again? She went down to Florida, laid out in the sun, started it all over again. And she did that 3 years in a row before we were able to get through to her that this was a bad idea. So photosensitivity can cause a rash, but it can do more than that. Serositis, we're thinking about pleurisy and pericarditis. I think most people are pretty comfortable with that. Pulmonary involvement, most of the time we're thinking about pleurisy, but you can see pneumonitis, you can see pulmonary hemorrhage, pulmonary embolism, pulmonary hypertension, and this weird thing called shrinking lung syndrome. All are associated with lupus. Cardiac involvement, pericarditis is probably the most common, but you can see every layer of the heart involved with myocarditis and endocarditis too. And then, like I mentioned, now we're starting to recognize that coronary artery disease is becoming more and more of a problem. Musculoskeletal involvement in lupus is pretty common. Having joint pain and muscle pain is common, and one of the things that we have to do clinically is distinguish between having joint pain and joint inflammation, because they're not exactly the same thing. The inflammatory joint involvement in lupus is polyarticular. It's inflammatory, it's symmetric, it likes the small joints of the hands and the feet, so the PIPs and the MCPs. But what differentiates this from the arthritis of lupus is that it's non-erosive and non-destructive. And so they can develop deformities like these swan neck deformities that I'm showing here in the picture. But if you put your hands or put their hands flat on the table, those deformities return to normal. Whereas somebody with rheumatoid arthritis, typically once those deformities start, they become permanent. Neuropsychiatric involvement in lupus, the diagnostic criteria lists seizures and psychosis, but the most common thing is an organic brain syndrome, in which over a period of time, people lose a little bit of cognitive ability, a little bit of memory, and it's hard to pick up unless you're actually doing neuropsychiatric testing, but it's pretty well described. Depression's pretty common. Stroke, peripheral neuropathies actually are not common, but all get lumped into this neuropsychiatric category. CNS lupus, again, encompasses a lot of different clinical manifestations, and I've listed a few here. Stroke, coma, cranial neuropathies. And usually when we talk about CNS lupus, the first thing that comes to people's mind is often that they have vasculitis. And that's actually not the most common manifestation. The most common thing is some kind of vasculopathy. So there isn't actually inflammatory change. There may be antibodies directed against the neuron. It may be antiphospholipid antibodies that plug up the vessels. Vasculitis occurs, but it's actually not very common. Okay, renal involvement. So we think the reason why it happens is that people with lupus have antibodies against double-stranded DNA. And it binds to loose double-stranded DNA, forms an immune complex, circulates through the blood, and ends up depositing on the glomerular basement membrane, fixes complements, starts an immune response which damages the glomerular basement membrane. And in fact, if you look at this particular picture here, here is an electron micrograph of a glomerular basement membrane that's relatively healthy, but if you follow it up where this green arrow is, this thickened, darkened material are actually immune complexes that are deposited in the glomerular basement membrane and disrupt its ability to do what it's supposed to do. Now, depending on the clinical manifestations of the renal disease, the World Health Organization has broken lupus nephritis down into these different categories. Categories 1 through 6. The most common that we see in somebody who's recognized as having renal disease is mesangial, focal proliferative, diffuse proliferative, and membranous. The question comes up with renal involvement: should we biopsy or should we not biopsy? And this has been debated back and forth by nephrologists and rheumatologists and others for a long time. And in somebody who has obvious lupus, and you look at their urine, the urine has protein and red cell cast, their creatinine's elevated, their blood pressure's elevated, there's not too many surprises here. And some people would argue that this is the kind of person that we probably don't need to biopsy because chances are pretty good that they have proliferative nephritis and probably diffuse proliferative nephritis that requires very aggressive therapy. On the other hand, nephrologists sometimes will say, you know, sometimes these people are sick and maybe they have coexistent acute tubular necrosis. Sometimes they have interstitial nephritis from the antibiotic you're giving them. Sometimes they have drug effects, and if we're not really sure about that, then maybe we should do the biopsy to know how much is the lupus and how much is the interstitial nephritis, and what can we expect from our therapy. So I'm going to talk about therapy a little bit later. Questions about lupus nephritis? Wow, this really is like church. Okay. All right. There are other clinical manifestations, including lymphadenopathy, splenomegaly. Gastrointestinal has a lot of different things with mesenteric vasculitis, protein-losing enteropathy, hepatomegaly. Pancreatitis has been associated with it, mesenteric vasculitis or diffuse vasculitis. And then ophthalmologic manifestations have all been reported in there. Okay, true or false? ANA titers change with disease activity. So you have a lupus patient. Today they're not active. Tomorrow they're active. Does the ANA titer change? Her few truths. And the answer is false. There is some lab who's our lab person? Oh, the whole group here. So there is some lab variation within the lab depending on how you do the test. So it can go up or down a little bit just by virtue of the actual lab test. But in general, the titers don't go up or down with disease activity. And so in general, once we have a positive test and we're convinced that the patient has lupus, we generally don't repeat the ANA unless there's something else that makes us let me see if I can rephrase the question. So are you asking, is there an ANA titer in which we need to worry about somebody with lupus versus somebody who just has a false positive ANA? Okay. So I'm going to talk a little bit in circles. So what I didn't say, and we'll get to it in a little bit, is with indirect immunofluorescence, what technique do you guys use here? Does Mayo, I think Mayo uses ELISA, right? Yeah. So with indirect immunofluorescence, positive ANAs, if you use a cutoff as 1 to 40, probably about 30% in the general population. I don't know what the cutoff is with the ELISA. So the university has bumped it up now to a titer of 1 to 80 to try and make it a little more useful as a test. So the higher the titer of the ANA, the more likely there is an autoimmune disease. Now, having said that, there are all sorts of people with lupus that have ANA titers of 1 to 80. So can you exclude somebody from having lupus by virtue of the titer? The answer is no. On the other hand, somebody who has 1 to 25/60 and I don't see much, I pay a lot closer attention to it. And in fact, that reminds me, Dave Gerbrock wanted me to talk a little bit about ANAs, and I wanted to pull out this article that I don't think is in my presentation. It might be, I can't remember. But there's an article written by Elizabeth Volkman that came out in 2012 called Using the Antinuclear Antibody Test to Diagnose Rheumatic Disease. And this is a very nice approach to what to do with antibodies. And it gets to what you're talking about, Dan. It talks about low titer, medium titer, high titer, what to do, how to follow it up, and things like that. So I'll leave this here. Maybe it's in my handout, if not. But this is a good article to have. Yeah? So the question was, if you followed up with a double-stranded DNA, what's the specificity? So I'll change the question a little bit. In somebody for whom I'm clinically suspicious has lupus, and they have a positive ANA and the double-stranded DNA is positive, the post-test probability of lupus is very high, 95, 96, 97%. Where we run into trouble is in someone who maybe we're not so clinically suspicious that they have lupus, because that data has never been collected. So for example, there's not a lot of experience with if you went out into Ames and did double-stranded DNAs in everybody, what would it show? Nobody's really quite sure what that means. So in a clinical suspicion, 30% probability or higher, it becomes a pretty useful test. Okay, hematologic testing, leukopenia, lymphopenia, thrombocytopenia, hemolytic anemia are all features of lupus. However, the most common manifestation is, she's still not looking at me yet. Nice to see you again. The most common manifestation is the anemia of chronic disease. Not very specific. We see it in a lot of other conditions, but it happens a lot in lupus patients. So this gets to some of the things that we were talking about, the immunologic laboratory tests. The Smith antibodies and the double-stranded DNA antibodies have high specificity for lupus. So in other words, in somebody for whom you have a clinical suspicion that they may have lupus and they have a positive ANA and then a positive Smith or double-stranded DNA, the probability of them having lupus is pretty high. I think I'll move on. So SSA, SSB antibodies we associate with lupus. They actually were found first in patients with Sjogren's syndrome. And they're also associated with, as I mentioned, the subacute cutaneous lupus, but also neonatal lupus as well. Antiphospholipid antibodies are an interesting phenomenon. You can measure them seemingly a million different ways. You can directly measure the anticardiolipin antibodies. You can measure an elevated PTT that doesn't correct. With normal plasma, you can measure a false positive VDRL or a false positive RPR. You can use snake venom, dilute Russell viper venom, to get a more sensitive PTT. You can directly measure beta-2 glycoprotein 1 antibodies. And there's a set of criteria with antiphospholipid antibodies to help guide us because they're sometimes elevated, sometimes not, and you have to measure them at a couple of times distant in time to feel comfortable that that's what's happening. Complement's pretty commonly used in lupus patients. If you think about it as a disease that's predominantly antibody-driven with immune complexes, it consumes complement as people become active. You can use complement levels as a barometer, if you will, of how active the disease is. And most of the time we're measuring C3 and C4. Occasionally, if I'm worried about somebody having a complement deficiency or something else funny with their immune system, I may measure a CH50. Does this get sent off to Mayo as well, or do you do that here? And does Mayo do a CH50 or a CH100? Do you know? 50? Okay. Okay, ANAs. So ANA stands for anti-nuclear antibodies. These are found in most of the patients with lupus, depending on what article you read. It's anywhere from 90 to 98% of lupus patients will have a positive ANA, but the backside of this is up to a third of the general population can have a positive ANA. So it's very sensitive, but not very specific. So what that means is if you see someone in the clinic or in the hospital who you think might have lupus, and you check an ANA and the ANA is negative, the chances are pretty good they don't have lupus. So it's useful in that way. If you order an ANA in somebody who's non-specific, they have fatigue, they kind of hurt all over, most of the time the ANA doesn't help you very much in those circumstances. If you go to an inpatient oncology unit, if you go to an inpatient neurology unit, the probability of those patients having a positive ANA goes up to 50 or 60%. Now, the ANAs were done initially with an indirect immunofluorescence technique, and that's the technique that I think most of us are familiar with. Shows us the patterns here in the picture, gives us the titers. Titers don't change with disease activity, but about, 10, maybe 15 years ago, different labs started to use ELISAs to measure ANAs. And the reason that they did it was because you can do a bunch of ANAs at the same time. So it cut down on tech time, it became less expensive, and the turnaround time was much faster. And for a long time, most of us were sort of wondering how the ELISAs and how the indirect immunofluorescence results were going to compare. And the expectation was that the ELISAs were going to be a lot more sensitive because most of the time ELISA techniques are pretty sensitive. But it turned out, interestingly enough, that just the opposite was found. That the ELISAs weren't sensitive enough, and so the rate of false negatives is higher than the indirect immunofluorescence. So the American College of Rheumatology came out with a recommendation that the initial screening test should be done with indirect immunofluorescence, and then later, if you want to look at it a little more carefully, use the ELISA technique. Now, interestingly enough, I think Mayo still uses ELISAs as their screen. And I've been dying to ask some of their immunopathologists why. So I don't have a good answer why they do that. So just keep that in the back of your mind, that the ELISA tends not to be quite as sensitive. And to make things even more confusing, as if rheumatology wasn't confusing enough, a lot of immunopath labs now have adopted this international recommendation on how they report out ANA findings. And if you look, and this is hard to see, but if you look right here, they list cytoplasmic patterns. Now, if you think about it, ANA stands for anti-nuclear antibody. So how in the world could they report out a cytoplasmic pattern? So what they said was that the term ANA now is outdated and even confusing, because what we're really paying attention to now are antibodies against all sorts of cellular entities. So not only the nucleus and stuff in the nucleus, but stuff in the cytoplasm and stuff in the cell membrane. And in this article, they talked about maybe what we should do is change the name of the test from ANA to ACA, so anti-cellular antibody. Anybody have a headache yet? So the university's immunopath lab has started using this recommendation for reporting results. And it's driven a few of the rheumatologists crazy because we see these cytoplasmic recommendations. So I don't know, is Mayo doing any of this? Do you know? Haven't seen it yet? Okay. So this is something, so this came out in 2014 and they jumped on it pretty quickly at the university. I think you're going to see more of this as time goes on. Questions so far? Okay. And you remember the mnemonic for the lupus diagnostic criteria? Good. There it is. I'm going to skip this. We may come back to it if we have time. Okay, I'm going to talk about therapy a little bit. So I put down here in this statement, therapeutic decisions are guided by clinical manifestations. And when you see that statement, you go, well, of course. But it turns out that this particular statement is incredibly powerful in the clinic, and I'll tell you what I mean. So I may see a young woman who comes into the clinic who has oral ulcers, a little bit of chest pain when she takes a deep breath. She hurts all over. She has some fatigue. She has a positive ANA, and maybe that's about it. And I didn't keep track. Maybe she has 4 criteria, and so we've said, you have lupus. And now she's scared to death. And she wants to know how I'm going to treat it. And what I tell her is, maybe I'm going to add hydroxychloroquine, but you don't have kidney involvement, you don't have lung involvement, you don't have bad joint involvement. We don't need to do much. So my therapy is going to really be directed towards what organ systems I see that are actually involved. Now, it takes some talking, it takes some education, but then that person can relax a little bit. Just like the other person who I described earlier, who had the positive ANA, had renal disease, the biopsy showed renal involvement, had a high creatinine, doesn't meet the lupus criteria, but we know that if we don't treat that person with high-dose corticosteroids and maybe cyclophosphamide, their kidneys aren't going to do well. So therapy and thinking about these patients is really built around what organ systems are affected and how severely. Now, nonsteroidals are useful particularly for arthralgias and myalgias and maybe some mild arthritis. It's interesting that they may be the treatment of choice for pleurisy or pericarditis. We always tend to reach for steroids, but steroids seem to be associated with recurrences of serositis. So nonsteroidals are coming back in favor. You want to be careful. They have a lot of potential side effects, and it's old data. I don't think anyone's looked at it for a long time, but if you take all of the nonsteroidals that are out there and put them into a population, it's hard to show that there are any therapeutic differences. However, individual patients will tell you, oh, that one really works for me, but this one didn't do anything. So there seem to be individual differences, but at least in a population basis, there doesn't seem to be much difference. Hydroxychloroquine is useful in cutaneous lupus, arthritis, fatigue, serositis. But one of the most important things that's come out over the last several years is that women who have lupus and they continue to take hydroxychloroquine do better. They seem to have fewer flares. They seem to have less organ involvement. I don't think I put it in here, but one of the more recent things is they also seem to have some benefit in people with antiphospholipid antibodies. So in patients that have either known lupus or known antiphospholipid antibodies and they've had organ manifestations, one of the first things that we try and get them on is hydroxychloroquine because it seems to be associated with better outcomes. Typically, we're using 300 to 400 milligrams a day. We're trying to keep the dose at less than 6.5 milligrams per lean body weight. 2012, the American Academy of Ophthalmology came out with recommendations how we'd adjust it based on somebody's height. Now, there was just recently, within the last, I think, 2 weeks, an article about how to manage this that came up with another algorithm that I haven't memorized yet. And then retinal toxicity is one of the things that we're always aware of. And it's pretty uncommon anymore, as long as we keep it below the 6.5 milligrams per kilogram of body weight. It's a well-tolerated medication. Sometimes people might have an upset stomach or some diarrhea, and cytopenias are rare. Corticosteroids get used a lot in lupus. They work quickly, they can be life-saving, they can be organ-saving, but the list of side effects is really long. So usually what we're trying to do is limit the dose, limit the length of therapy. Arthritis, usually we're using 5 to 15 milligrams daily. Major organ involvement, CNS involvement, kidney involvement, we're using 1 milligram per kilogram, maybe 1,000 milligrams in IV pulses. Cyclophosphamide is the tried and true medication that's indicated in proliferative lupus nephritis that sometimes get used in other manifestations. CNS, we've used it sometimes in really bad cutaneous involvement. And what it was shown in lupus nephritis was that the outcome was better than prednisone alone or azathioprine. It's been a good medication, but it's relatively toxic with cytopenias, bladder toxicity leading sometimes to bladder cancer. It seems to have bad side effects on ovary and sperm. And typically what we're using is 0.5 to 1 gram per meter square IV in monthly. But there have been all sorts of new treatment regimens that have come up. The Eurolupus one uses 500 milligrams in IV doses every 2 weeks in different populations. And so researchers have been playing around with the doses of this for some time. Now, mycophenolate is the newer kid on the block. It is indicated in proliferative nephritis, and there's all sorts of data that shows that it's non-inferior. I love that phrase. And so I know what they mean in research, but it just strikes me funny that they chose that for a term. But typically we're using 2,000 to 3,000 milligrams daily. Side effects, cytopenias, GI, and it's becoming more and more used, I think, as we gain more experience with it. Belimumab is perhaps the newest medication. It was one of the first medication that was actually designed to treat lupus. And what it does is it inhibits B cells through BAFF and BLyS. It's not been tested for those with renal disease. So I see discussions sometimes in which they say, well, this person has renal disease, so we can't use Belimumab. Well, that's not quite true. So it's not been shown to be useful in people with lupus nephritis, but it's never really been tested. Adverse effects include infusion reactions and infused medication, depression, which I don't think anybody anticipated when it was first brought out, and infections. I think that the experience has been less overwhelming than people anticipated when it first came out. It was nice, and there was a lot of press when it first came out. This was the first specific medication for lupus in 50 years, and since then, I think it's been useful, but its effects have been less striking than people had hoped. Rituximab also inhibits B cells through a different mechanism. And interestingly enough, even though rituximab and belimumab both block B cells, the clinical trials of using rituximab in lupus failed to show benefit. And nobody could quite figure out why. There have been a lot of discussions and debate about maybe the study design was wrong, maybe the patients that they chose for it were wrong. Nevertheless, there are lots of case reports and case series of the use of rituximab in people that have failed everything else. Adverse effects include infusion reactions, hypogammaglobulinemia, infections. And then there are others. Colchicine, which is an older medication, now has gained more attention recently because it's been useful in serositis, particularly in pleurisy. And so first-line therapy for somebody with serositis is nonsteroidals. Probably the second-line agent is colchicine and not steroids, unless the effusions are really big. It's interesting. Azathioprine is an older medication that's been used as a steroid-sparing agent for a long time. Methotrexate's been particularly useful in inflammatory arthritis and, again, is a steroid-sparing agent. Okay, so I put this up, and this is the recommendations from the American College of Rheumatology for proliferative nephritis. And it's kind of nice. They walk through the individual therapies. So this is the World Health Organization Class 3 and Class 4, otherwise known as focal proliferative and diffuse proliferative nephritis on the left. And it walks through using either mycophenolate or cyclophosphamide, and then reassessment, and then thinking about what to do with therapy after that. And so you can see the low-dose cyclophosphamide one, which is the stuff from the Eurolupus trials, and then moving down into using azathioprine, and then down here at the bottom you can see azathioprine showing up again, rituximab, and then tacrolimus, and what's the other one that I'm blanking on? The older transplant medication. Say it again? Cyclosporin, thank you. Now, the figure on the right is the recommendations for the treatment of membranous lupus nephritis, which is class 5. And this has been controversial in the literature for a long time. European and American nephrologists and rheumatologists maintained for a long time that class 5 lupus nephritis didn't get better with therapy. There was a group in Italy, though. It was interesting. There was a group in Italy that said, no, you all are wrong, that it will get better. And they've convinced now the rest of the world's community. So even though there are lots of caveats associated with it, now most people are treating membranous lupus nephritis with mycophenolate and sometimes later with cyclophosphamide. A couple of caveats: avoid sulfa medications in people with lupus. They can activate lupus. Turns out estrogen at replacement doses can do the same thing. Birth control pills don't seem to do it, so low-dose estrogens seem to be less likely to do that, and tetracyclines also can be associated with flares of lupus. Questions so far? Some of it, but it seems to be more than that people don't really understand. So there is some photosensitivity to it, but if you put somebody in Bactrim and keep them inside, they can still flare their lupus. It's kind of weird. Yeah. Okay, how many of the 11 criteria needed for the diagnosis of lupus? You got it. Okay, so in summary, remember SOAP-brain MD, it's a nice thing to tuck away, so you got it in the clinic. ANA is found in about 93% of patients with lupus. Therapy is guided by clinical manifestations, really important concept. Smith and double-stranded DNA are very specific for lupus in the right clinical setting, and lupus can really vary from a life-threatening illness to a very mild disease that hardly affects lifestyle. I'll take more questions, and I did not put up. Well, maybe that is it. I don't know if I have that article. Questions? Yeah. Brain fog. So that's that organic brain syndrome. Nobody's really sure exactly what that is or what's caused by that. There are some theories, and you can find different data that says maybe it has to do with tryptophan metabolites, maybe it has to do with any phospholipid antibodies, maybe it's decreased blood flow, and maybe it's all of those things in different people, but it seems to be a real phenomenon and probably the most common problem with organic brain syndrome. And it doesn't respond to therapy, at least any therapy that we have so far, yeah. Mm-hmm. Nothing to do from a medication standpoint. The neuropsychologists have brain training and exercises and things that you can do to try and maintain the faculties, but there's no medication therapy that I'm aware of that's been shown to be consistently helpful. Fertility, so that's a complicated question. I'll start off by saying that in the 1950s and 60s, doctors told women that had lupus, don't get pregnant. So that was wrong. That women that have lupus can have babies and be healthy and do well. It does seem to matter, though, which organ systems that they have. So renal disease, CNS disease make it harder and increase both maternal and fetal morbidity and mortality. So usually what we'll do is if I have somebody in the clinic who has lupus and she wants to have a baby, we talk about it. She has renal disease, we want to make sure that the renal disease is quiet for at least 6 months. If she has CNS disease, usually we want it quiet for at least 6 months. We talk about medications and what are we going to continue. Usually we'll continue hydroxychloroquine, but not always. And then we'll check SSA and SSB antibodies because that's associated with neonatal lupus, and then any phospholipid antibodies. And then we'll get them into a high-risk OB clinic, and women do well. But it takes a lot of attention, a lot of cooperation by different specialties. Yeah.
As a neurologist, I've seen patients with Churg-Strauss angiitis with multiple mononeuropathies, and I've seen a number of patients with Sjogren's syndrome. But despite the fact that some physicians order an ANA for a polyneuropathy workup, I've never actually seen anybody with SLE that's had a neuropathy. What is the more common presentation for lupus patients that have a peripheral neuropathy? Is it a polyneuropathy? Is it a multiple neuropathy, or what?
I think both are described. It's not very common actually within lupus, but you're right, because the neurologists at the university, as a part of their evaluation for polyneuropathies, will order an ANA as a part of their screen. And along with it, rheumatoid factor 2, which was something I'd never seen until I came to Iowa. Depending on which population studies you look at, you can see an association with a polyneuropathy that's axonal, that's both sensory and motor. But it's pretty, I won't say it's common, but it's common enough and it's idiopathic that no one's sure if they're being caused by one another. So I think probably we see more polyneuropathies than we do mononeuritis multiplex, but both happen, and neither one's very common, I don't think. Yeah, I'd be happy to. I don't know if anyone's actually aggressively looked at a diagnostic criteria for drug-induced lupus. Basically what they'll say is people with lupus manifestations that take a drug and those manifestations go away when you withdraw the drug. Some of the other characteristics of drug-induced lupus are that they have typically an antibody. If you measured it indirect immunofluorescence, it's a diffuse antibody pattern. And when you look more specifically, they have histone antibodies. And interestingly enough, different drugs have different histone antibody profiles, so you can even get more specific. I mean, the common ones are procainamide, hydralazine, and then there are less common ones as well. And so the recommendations are, if you suspect a drug, withdraw it if you can. If everything goes away, then it was probably drug-induced lupus. Hydralazine has become more and more popular. And the other catch is if you take somebody who has native lupus, so they've had lupus that they've had since they were 22 years old, they will have histone antibodies too. The difference is that somebody with drug-induced lupus won't have Smith, double-stranded DNA, SSA, SSB antibodies. They only have the histone antibodies. So that's the reason that I might repeat an ANA after it's been positive. So if I see somebody who's been on hydralazine and we stop it and their manifestations go away, I may repeat the ANA later to see if it goes away. Or if somebody had a viral syndrome and they had a positive ANA, and I may repeat it to see if it went away, but most of the time I don't. Does that help? Okay. Yeah.
I'm the director of the Infusion Center at
Hi.
McFarland. Hi. And we see quite a variation of pre and post hydration for cyclophosphamide infusions. Do you have a standard there at the University of Iowa with regards to how much you vigorously and or not hydrate patients?
Yeah, I think they're like 4 or 5 or 6 or 7. You know, I think it came out, if you go back and look at the original lupus trials, which were done at the NIH, the people that were volume expanded both before and after cyclophosphamide did better with less bladder toxicity. And so I think in general that's been the overriding guiding principle. However, we moved it from when I was a resident to doing cyclophosphamide infusions as an inpatient to doing it in infusion centers now. And so people have gotten creative about how much fluid to give, both pre and post. And some of it depends on who the patient is. Some of it depends on bed turnover in the infusion center, how long you want them to sit there. So I have a couple that I use in my standard orders that came from both the original lupus trials and what the nephrologists have built using the infusion center. But there's a lot of variability, as you're probably seeing. I mean, I'd be happy to send you what we got, but if you polled 5 nephrologists, you'd probably get 5 different answers. So, you know, I think the best answer is the more you can flush the kidneys and keep urine flow, the better they're going to do, because the theory is that the cyclophosphamide gets metabolized to acrolein, which sits in the bladder and damages the bladder mucosa. So if you can flush that acrolein out of there, the toxicity is going to go down. How fast is your bed turnover or your chair turnover?
Depends on the day.
Yeah, that would be the answer at the university too. Other questions? All right, thank you everybody.